believe we're at item number 13, AB 1223, O'Donnell Emergency Medical Services, Ambulance Transportation. Good afternoon.
Good afternoon, Mr. Chair. Are you ready? Thank you. Good afternoon, Mr. Chair and committee members. Today I'm presenting AB 1223. This bill takes the first step in addressing ambulance patient offload time, or wall time, at hospital emergency departments by defining the term and creating a standard for measuring and reporting that. This bill comes out of my experience as a Long Beach City Council member. Whenever I met with our firefighters, the issue of wall time would come up. They'd be waiting to get patients into a bed so they could go back into service. When firefighters or any EMS crew picks up someone in an ambulance, the crew is responsible for their care until they are signed over to a hospital emergency department. When there are delays in the admission process, the crews must wait, leaning against the wall with their patients until they can be admitted, hence the term wall time. A national study of more than 200 cities found that wall time at emergency departments had more than doubled since 2006. There is currently no consensus among counties, hospitals, and local EMS agencies over what wall time is or how it should be measured. Without a common vocabulary, the state can't begin to identify the causes of this problem, let alone help fix it. This bill requires this common vocabulary by defining wall time. With that, I have a couple witnesses here, Mr. Chair.
Good afternoon, Mr. Chair and members of the Senate Health Committee. I'd like to thank First Assembly Member O'Donnell for bringing this important bill forward. My name is Tracy Hansen. I am the Fire Chief with the Cosumnes Fire Department here in Southern Sacramento County, and I am also I'm honored to be the President of the California Fire Chiefs Association, representing over 3,000 chief fire officers and agencies across the state. I'm joined here today by my colleague, Battalion Chief Ted Peterson with the Novato Fire Protection District and a member of the California Fire Chiefs Emergency Medical Services Section. We're here today to speak in support of AB 1223, addressing the impacts of ambulance transport services across the state. More and more people across the state are using the emergency department as their gateway to health care, and often those patients are transported by ambulance. The delay in offloading patients decreases the number of ambulances in the system to respond to subsequent life-threatening emergencies in the respective emergency services system. When there are less ambulances to respond to calls, fire department engines and trucks remain on scene longer, decreasing the number of available firefighting resources to respond to other calls for service. This offload time, dubbed as wall time, as was described by the Assembly member, is often a regional issue and different for each system. What may be an acceptable wall time in one region of the state may be excessive in another, depending on the demands for service and the service delivery design. Some regions have reported wall times that exceed several hours, even at times up to 8 hours, while others have experienced wall time impacts of only 30 to 40 minutes. Each may be extreme for their first responder and ambulance system design, and thus the importance of allowing the local emergency medical services agencies the ability to develop the non-standard patient offload time thresholds.
Lost production in the form of less available resources to respond to emergencies requires private industry ambulances to increase staff, which will result in decrease in revenue. Taxpayers assume the burden of cost and delayed response in areas where there is a public service provider serving as a first responder as well as ambulance transport. Several fire agencies across the state, including those in Los Angeles, here in Sacramento, and San Francisco regions, have reported millions of dollars per year in lost production as a result of firefighters and paramedics standing in the hallways and waiting to offload their patients. Many ambulance providers across the state are penalized by their local emergency medical services agency for not meeting response time standards. These penalties come in the form of fines, which can amount to hundreds of thousands of dollars. In some cases, this inability to meet these response times are due to the unit's impact of wall time. This bill requires a standard methodology for calculating wall times, but allows the local EMS system to establish what constitutes an acceptable non-standard patient offload times. For these reasons, the California Fire Chiefs Association supports 1223 and urges an aye vote. Thank you very much.
I'm Johan Claes, representing Paramedics Plus, the county's 911 EMS provider. We have a 97% on-time response record, one of the highest in the state. But even with a high record of on-time responses, wall time still affects the performance of our company in being able to save lives in Alameda County. We partner with the fire service in every opportunity we get. We think it's an important bill, and we ask for your aye vote.
Mr. Chair, members of the committee, Christy Bauma on behalf of the California Professional Firefighters, also pleased to be in support of this measure, and I'm also here speaking today on behalf of some of my local members, the Long Beach firefighters and LA City Firefighters Local 112, who are the culprits also who speak to the Assembly member about this issue on a regular basis, and I would just compliment the Assembly member on his approach. It's an identifiable problem acknowledged by all stakeholders, and so convening those stakeholders to arrive at a methodology that will drive a solution is a good approach, and we urge your support.
Mr. Chair, committee members, Maurice Johnson, Assistant Chief and Director of Emergency Medical Services for Sacramento Metro Fire Department. We're here to express our strong support for this bill. Thank you.
Mr. Chair and members, Assistant Chief Scott Williams, Director of EMS for the City of Sacramento Fire Department, and we urge your strong support for this.
My name is Afrak Vargas. I'm with the California State Firefighters Association. Seeing Senator Roth here stand by the door, I'm going to ask for an aye, for your aye vote.
Opposition? If we can make some room for the opposition, please.
Good afternoon, Mr. Chair and members. Connie Delgado with the California Hospital Association. I do want to thank the author and his staff for their continuing conversations regarding this issue. It is clearly an issue that needs to be addressed. I would like to introduce Harris Koenig, CEO, who will give you a little bit more information about our opposition.
Good afternoon, Mr. Chairman and members of the committee. I'm Harris Koenig. I'm here representing California Hospital Association. And I want to provide you with some comments on the Assembly Bill 1223. I'm the President and CEO of San Antonio Regional Hospital. We are one of the busiest paramedic base stations in the Inland Empire. I sit on the Inland County's EMSA Emergency Medical Care Committee as the hospital representative, and I'm also actively involved in the Inland County's APOD initiatives. CHA opposes AB 1223 predicated on three principles. First, APOD is only a symptom of a very complex problem. Second, selecting this system to monitor infers that hospitals are the major contributor to the problem or a sector that can cure the problem, both of which are false. Third is that what is applicable in Los Angeles might not be applicable in San Francisco. What's applicable in Eureka may not be applicable in Victorville. With regard to these issues, I would offer the following facts in support of our opposition to the bill you are considering. APOD is a symptom of a much larger problem, ever-increasing demand for ER services. In many instances, fixed hospital building supply and licensed capacity is a real barrier to resolution of this issue in the near term. While hospitals and EMS providers are sharing and implementing best practices for efficient throughput, in the end, there are only so many ICU beds, heart monitor beds, emergency room bays, or even ambulance rigs and staff to serve these patients. Second, the increased demand for emergency services can be attributable to population growth, but added to this demand are the following factors. The Affordable Care Act has resulted in ensuring about 3/4 of the uninsured population through expansion of Medi-Cal and the subsidies available through Covered California. It's a well-known fact that newly insured individuals utilize health care at a high rate for a period of time. Prior to the ACA, many physicians and providers started to close their practices to new Medi-Cal patients, and this problem has become worse since the ACA. As long as Medi-Cal reimbursements to the physicians are inadequate, the growing shortage of primary care physicians will be exacerbated, which in turn will result in many people accessing expensive emergency room care and oftentimes using their ambulances unnecessarily. the ever-growing utilization of ERs by people suffering from mental illness as well as intoxicated people, and how law enforcement is dealing with these people is taking a big bite out of critical emergency room capacity. These people are often placed on 72-hour hold as they are considered a danger to themselves and others. They arrive at ERs because they may be suspected of having some underlying medical problem. Once they are medically cleared, it is virtually impossible to discharge them or move them to a psychiatric facility. These people remain in our ERs for 3 or more days to access proper and necessary treatment. Consequently, they sit in ERs taking up space that could be used to take care of emergent patients. Recently, Senator Jeff Stone held a meeting in Palm Springs area to gain further insight into this real problem. An LA Times article a few days ago addressed the impacts on law enforcement relative to this same systemic problem. Over the past 3 decades, we have moved from institutionalization of people with mental health problems to deinstitutionalization, and more recently from incarceration to a pseudo form of hospitalization. The mental health care system in this state, and arguably the country, needs to be properly structured and funded to have an impact on burgeoning ER capacity constraints. Lastly, one size does not fit all. 60% of the local EMCAs and hospitals report no problem with APOD. For the remainder, the EMSA regions are different as to how and where the issues noted above manifest themselves. The number of agencies that are involved, be they transport providers, municipalities, counties, and resources available to address these problems. In the Inland Empire, through the cooperative work of hospitals, local EMSAs, the counties, and other stakeholders, we are reducing the frequency and duration of APOD. We have also started to work to address a unified dispatch and base station concept and forming a task force to address the significant increase in the use of ERs by people who suffer from mental illness. We would respectfully suggest that focus be placed on solutions to the causes of APOD and allow local areas to relieve the pressure of excess demand on hospital ERs. It is for these reasons that CHA asks for your no vote on Assembly Bill 1223.
Thank you.
Thank you.
Senator Roth.
You know, I'm sensitive to the issues and problems that hospitals have in this area. I sat on a few boards myself in my rather long life. But I also spent a little time in the military, and what I learned from the military, we used to say what gets measured gets done. Mm-hmm. And I recognize that this is not a one-size-fits-all issue, and that hospitals and the EMS area may not be able to solve it, and it may not be your problem. But wouldn't we be better off developing some standard methodology to figure out this issue and with input? Because as I understand it, the bill requires IMSA to develop with input from stakeholders, including hospitals and providers, this methodology. Wouldn't we be better off starting with something, and then to the extent we have to modify this because it unfairly puts a system in a bad light when it's not the system's fault? I guess that's a question, sort of.
Thank you. And as a manager, I understand the idea of measuring and improving, but the issue here relates to the fact that in different areas this shows up different ways. And I think that the bill, while it's well-intended, is trying to create a statewide framework to address this issue. And I think that, for example, in the Inland Empire, we've come up with our own way of making definitions and our own way of trying to address it, given even the diversity just in San Bernardino County, for example, at Riverside County. So I don't think that the bill is necessary in the context of starting to set some kind of state framework. We are measuring, and we are measuring different things, and our definitions may be different than definitions that may be set in other areas. We're making progress in our area, Mr. Senator.
But if I were interested in trying to address the problem and fix it, recognizing that the hospitals haven't created it, am I able today to go to one location to determine what the wait times are in Northern California or the Central Valley or inland Southern California and make sense of the data because I know with confidence that people are using the same measuring criteria and the data is pure and the data at your institution is the same as the data coming out of a Riverside Community Hospital and the same data that's coming out of Arrowhead Regional or Riverside County Regional Medical Center?
I'm not aware of any unified measure, Mr. Senator, and I just believe that we should be dealing with this on a local basis. That's all our position is. I appreciate your point.
I mean, recognizing that if your wait time is twice as long as the wait time in inland Southern California, for example, St. Bernardine's, it may be because you have a different business model, you have a different geographic and demographic situation. You're taking 4 times as many patients in to the emergency room than they are at St. Bernardine's or San Bernardino community. And there's an explanation for the difference in the statistic. But at least if we had a standardized measuring system or tool, we would be able to tell that the 4 times you're reporting relates directly to the data we're getting from St. Bernardine's, right?
I think that the idea is, and the difference is, one, that the local areas can make these definitions. I don't believe that you need to start to create a statewide framework. If the interest is to make area-to-area comparisons for some reason down the pike, possibly, there's merit in that. But I just believe that there are so many disparate stakeholders in these local areas that with so many different ideas about what these things are, that it's complex enough to deal with it even in a local area, much less start to create some kind of statewide framework.
But from a state legislature's perspective then, and I realize some would argue this is appropriate, we're essentially ceding authority to the local jurisdictions to measure and deal with the problem to the extent a problem exists, because up here we don't have any standardized data with which to operate and evaluate, right?
I appreciate that.
Right. Anyway, thank you very much. Appreciate what you do.
Yes, sir. Thank you.
Senator Pan and then Senator Nielsen.
Okay. Yeah, I too actually share Senator Roth's actually somewhat. Are you puzzled? I'm puzzled at the opposition. Because at least how I see this bill is that's about developing a standardized measuring tool. I agree with you that each locality may have different circumstances that are creating a problem. There may be several localities you've testified that don't have this problem at all. But having a standardized measurement is actually is critical to figuring out what's going on, not only locally but across the state. In fact, when we have quality measurement tools, one can argue each hospital and each practice area is unique, but yet we've established not only statewide but nationwide quality measurement standards. The solutions to how do we raise that quality may be different and tailored to each individual area because different factors may come into play. But this is not about, at least I don't view this as about blaming the hospital for everyone getting backed up. I think this is about defining the problem. And if we have standardized tools, we're going to more effectively do that, because some of the solutions and some of the things, in fact, that was testified to in the opposition were actually solutions. You're probably going to come to us and say, oh, by the way, our payment rates are too low, or you're providing incentives to people to use the ER instead of getting to primary care or something else, and you're going to want statewide comparable data to say, look, across the state, and we can point to this area and this area where we have these problems where everyone's getting backed up in the emergency room because, I've worked been in a hospital because, right, we don't have enough inpatient beds. We don't have the equipment we need because the payment's too low that we can't get it, that it gets people from the ER out. So, of course, that backs up the whole system, right? So the ambulance shows up and you have no bed in the ER. You have no bed in the ER because there's no bed in the hospital. There's no bed in the hospital because there's a discharge something that we couldn't get someone out. But I would think that you would be strongly, you have to decide for yourself, but I would think you'd be strongly in support of this bill to try to develop standardized measures so we can better have this kind of data. So, and I certainly, so anyway, I would just say that I think from my perspective as both a policymaker, but also someone who has a background who's interested in quality measurement and public health and trying to figure out system solutions, I think this is an excellent bill. And in fact, it includes hospitals, a stakeholder process, develop a statewide measure, and then let's get the localities to figure out how they're going to solve the problems that they see.
Mr. Chairman, first, Doctor, would your data that you gather, does that account for the type of individual who's showing up? In other words, you designate this person that showed up the ER as a 5150, he's a felon on parole, a probationer. Do you have that kind of information?
At some of the individual hospitals, they are collecting that data, especially the ones that are more impacted in that way. But we find that there's been a consistent increase in the number of 5150s that are being brought to the emergency room and needing to be screened, but then held. We end up getting the patient, and they end up having to stay oftentimes many days before we can transfer them out.
Well, I'm dealing with some cases right now with hospitals in the area that I represent. I've dealt with them for years as chairman of the Board of Prison Terms. They're called 5150s and one thing. And I'm sympathetic to the bill in terms of getting data, and I'd like to see that kind of data specified as being data that is represented. What is the nature of the patient that's showing up? What is their problem? Because here's what we're going to find out, ladies and gentlemen. It's the California State Legislature that's made the impact, the greatest impact on the ER by realignment. We have put into our community unstable individuals and criminal felons. And when they decompensate or have a problem, they get delivered to the ER. I've seen that happen. California State Corrections Agency paroles, drives the parolee right from the prison to the ER when they've been paroled. So we have to, the legislature has to look unto itself for the problem that the legislature has created. And if there's going to be data, I'd like to see data that will trace then those individuals that are the responsibility of decisions of the legislature, and we need to take a look at that, what dangerous individuals we're putting in our communities.
Any further questions from any of the members? Seeing none, is there a motion? Moved by Senator Pan. Chair is recommending support. Would you like to close?
Respectfully ask for an aye vote.
We're at item number 13, AB 1223, due pass to appropriations. Call the members.
Hernandez.
Aye.
Hernandez, aye. Nguyen. Hall. Mitchell. Monning. Nielsen. Pan. Aye. Pan, aye. Roth. Wolk. Aye. Wolk, aye. Roth. Roth, aye.
Currently has 4. We'll place that bill on call.